Hi, my name is Keyvan Karkouti. I'm the head of Department of Anesthesia and Pain Management at the University Health Network, Sinai Health System, and Women's College Hospital. For my disclosures, I have received research funding and honoraria as part of consultancy work for Octapharma, Instrumentation Laboratory, and Bayer. I have two objectives for this presentation. One is to review how the massive hemorrhage protocol needs to be modified for post-cardiac surgery bleeding, and then provide an overview of the role of viscoelastic testing that we use in cardiac surgery. Cardiac surgery is a special situation. You'll notice that it's quite different in many ways from other bleeding situations, and I'm going to divide and present the differences under these headings in terms of the prevalence of major bleeding, how we predict whether patients are going to bleed or not, how we prepare for the bleeding patient, and then go over some of the pathophysiology of what causes bleeding and how do we go about managing the bleeding causes in cardiac surgery. In terms of prevalence, major bleeding has various definitions, but if you look at this definition that's been used many times since it was published in 2014, if you consider major bleeding as anybody who needs more than five or more units of red cells or plasma, has major bleeding in the chest tubes that go in during surgery, needs surgical re-exploration due to bleeding, or needs rescue therapy with factor 7A, in cardiac surgery across Canada, when we did a study in 2016 to see whether we could make a difference in major bleeding, what we found was that the incidence of major bleeding was quite high. Here are the 12 hospitals that participated in the study. And on the y-axis, you have the incidence of major bleeding according to the definition I just showed you. Although there was wide variability across the hospitals, you can see that on average, about 1 in 5 or 20% of patients having cardiac surgery have major bleeding. Moving on to prediction, there are many factors that we can use to determine whether or not, what the chances are of a patient bleeding. Starting with patient characteristics, there are some things that put patients at higher risk, including older age, their female gender, and whether or not they have preoperative anemia. Also, a lot of patients are on anticoagulants or have diseases that impact their coagulation. So if they're coagulopathic when they come for surgery, they're going to be at increased risk of bleeding. And then we have more predictive factors that happen essentially that relate to the type of surgery or any complications that may happen during surgery. So if they're having redo surgery, if they've had cardiac surgery before, or undergoing complex surgery, for example, multiple valve surgeries at the same time, they would be at increased risk. The longer the CPB duration or the pump run, the higher the risk of major bleeding. And then obviously, if there are technical issues that lead to complications such as dislodging the cardiopulmonary bypass cannula or difficult to control surgical bleeding, for example, behind the heart, if there is major bleeding, it's difficult to get access to. Those things would increase the risk of a patient having major bleeding. Now, one factor that's special in cardiac surgery is bleeding really doesn't become problematic until you're off pump and you've reversed the heparin that we use to anticoagulate the patients while they're on pump. Until that point, any blood that's lost is simply suctioned back up and given back to the patient through the heart-lung machine. And the other special factor is that while we're on pump, near the end of it, we can do some coagulation assays to see, to determine what the chances of, what the coagulation status is and what the chances of bleeding are. Some of the assays we can do include a complete blood count, so we can measure the hemoglobin and platelet count. We can measure the fibrinogen levels using a Klaus method, and we can use point-of-care coagulation assays. Viscoelastic tests and platelet functions are two of the more common ones. Using these tests, which are very predictive for bleeding, we can therefore prepare the patient and ourselves to manage the bleeding. How do we prepare? Well, we have medications that we can use before the patient bleeds. So antifibrinolytics are given to every patient having heart-lung surgery with a cardiopulmonary bypass machine prophylactically, and we adjust the dose based on the risk of bleeding that the patient has. We can prepare with specialized devices such as a cell saver to suck the patient's blood back up, wash it, and give it back to them. or level 1 blood warmers to transfuse massive amounts of blood products and keep the patient warm at the same time. And then in terms of transfusion practice, because we know what's coming up and we can prepare for it, there is less need for actually having a massive hemorrhage protocol called. We more or less most times are able to modify the transfusion practice and provide targeted therapy for patients based on what's causing their bleeding. The physiology of bleeding in cardiac surgery is also different than most other situations. And the special factor here is the cardiopulmonary bypass. When the patient's blood becomes in contact with the CPB circuit, there is physiological changes that can eventually lead to coagulopathy and major bleeding. Specifically, there is thrombin activation and consumption of coagulation factors. There is hemodilution because the CPB circuit adds about 1.5 to 2 liters of fluids to the patient's blood. Patients get hypothermic. There's ongoing surgical blood loss during and after. And then, of course, we use heparin, and then we reverse the heparin with protamine at the end of the case. And all of these factors can cause coagulopathy. The three main defects that happen during cardiac surgery, the most important one is the effect on platelets. You get a drop in platelet count and also get a significant platelet dysfunction. The second most important one is you get low fibrinogen levels or acquired hypofibrinogenemia. And then the third factor is that you get impaired thrombin generation capacity due to coagulation factor depletion. So these are the three areas that we address when we're preparing and treating the bleeding patient. Focusing on fibrinogen, this is a study that we published a few years ago now that shows that the triggers that we use in cardiac surgery are different than in other settings. So here is an observational study where we looked at bleeding, when we looked at fibrinogen levels after cardiopulmonary bypass and looked at the relationship between the level and the probability of having major blood loss. And as you can see, once patients drop below 2 grams per liter, the risk of bleeding goes up substantially. Whereas our thresholds for other settings are to treat fibrinogen levels below 1, for example. In cardiac surgery, we aim at higher levels of 1.5 to 2 grams per liter. Putting it all together, you can come up with transfusion algorithms. And here is one that we studied in 2016, and it's been modified, and a version of it is still in practice at our institution and several others. But basically what I want to point out here is that there are multiple facets to managing the patient once they come off pump in terms of bleeding. On the top there, you'll see that we check, we give protamine, make sure the heparin is reversed, and then we assess for bleeding. Once we identify a bleeding patient, then we target the three treatment strategies that I mentioned in previous slides, which would be treating platelet dysfunction or low platelet count, treating low fibrinogen levels with cryoprecipitate or fibrinogen concentrate, and then treating low thrombin generation capacity with either plasma or prothrombin complex concentrates. Now we tested the ability of this algorithm to see what effect it has on managing bleeding. And I'm just going to go back to one of the slides I showed you earlier in terms of major bleeding. So this was the 12 hospitals that I mentioned and the major bleeding rates that they had. Now the new information is that we divided the bleeding rate into before the algorithm was instituted at the hospitals and after it was instituted. And the light blue bars are the rates before, and the dark blue bars are the rates after the algorithm was instituted. You can see that there was that in almost every hospital there is a reduction in major bleeding. And in fact, if you do an analysis of the effect of the algorithm, you'll note that we noted that there was a relative risk reduction of about 20% in the incidence of major bleeding, and that was highly significant. And what it told us was that you need to, essentially for every 22 patients or so that you treat with this algorithm, you save 1 patient from having major bleeding. Now, looking at how we use viscoelastic testing in cardiac surgery and what impact it has on how we manage the bleeding, I'm just going to present a case of massive bleeding after cardiac surgery and how we use viscoelastic testing to manage the patient and what difference it makes in terms of how we would otherwise approach the bleeding patient. Before I present the case, I'm just going to show you what a normal ROTEM looks like. So this is viscoelastic testing parameters that we would get in when we do a ROTEM. So on top, you have what they call the XTEM. So it tests the extrinsic component of coagulation. And what happens is when you start the test on the left side, you get a line until the clot starts forming. And that time period is called the clotting time. As the clot forms, the lines divide and you get the graphic pattern of clot formation. And the maximum clot thickness is essentially the height of that blue part of the slide. And that's called the MCF. And in this case, it's 57 millimeters there, as you can see. So this is a normal clot, and the clot stays strong as the test continues moving forward. On the bottom is the same plot, except the action of the platelets have been removed. So this measures only the fibrinogen component of the clot. So you get the same pattern, but it's a lot narrower because now the platelet component is removed. So this is what we use to determine whether or not a patient should receive fibrinogen concentrate or cryoprecipitate if they're bleeding. And that's called the FibTem, and the value that we use to treat patients is less than or equal to 8 millimeters. And here, for example, it's 10 millimeters, so this patient has adequate amounts of fibrinogen levels. So with that in mind, I'm going to present the case. So this was a complex cardiac surgery. This particular case, we can say, was a heart transplant. And this is the point of care assays that we did before the patient came off pump. So this was an all-day case. Rewarming, that means the patient was almost ready to come off pump, was happening at about 2:30 in the afternoon. So this is this ROTEM assay that I showed you earlier in the last slide. And as you can see, this looks quite different than what I showed you before. And I'll go over how it looks different and what's abnormal here. We also measured for platelet function and platelet count. So this patient's total platelet count was 83, and functioning platelet count was only 37,000. So substantial thrombocytopenia with a lot of platelet dysfunction. Looking at the ROTEM, the clotting time, which is the initiation of the clot formation, was 116 seconds. The normal ranges are in brackets. As you can see, this was substantially elevated. The clot formation time, or CFT, is the uptake of the angle, or how fast the clot is forming once it started forming already. And at 412 seconds, you can see it's also 4 times or so higher than the upper limit of normal. And the A10, which is the measure of the thickness at 10 minutes, is 24 millimeters, which is half of what it should be at the lower limit of normal. So this is a really abnormal ROTEM measure. In the bottom, if you look at the FibTem, it's more or less a straight line. There is not much of a split in that graph, and the thickness is only 4 millimeters, which suggests that this patient has really low fibrinogen. So in every way, this patient's coagulations are abnormal, so it's not very hard to predict that this patient is going to bleed massively. Knowing this information, we would have all the steps that I mentioned earlier on in terms of preparation. We would call the blood bank and get the blood products we think we need in the room and be ready for reversal of the heparin and treating this patient's bleeding. So once we came off pump and the patient obviously started bleeding based on these lab tests, we started our treatment of massive bleeding. And what we gave the patient was 2 units of red cells. I didn't mention the hemoglobin, but our goal here is to keep the hemoglobin at about 100 grams per liter. So we used 2 units of packed allogeneic red cells, and then a lot of cell saver blood to maintain the hemoglobin at 100. We gave 2 doses of platelets, 4 units of frozen plasma, and 4 units of fibrinogen concentrate, which is equivalent to 10 units of cryoprecipitate. Once we'd given all those products, they were ready, so they would have gone in very quickly. And we repeated the test. So we came off pump at about 5 minutes to 3 or so. Within 20 minutes, we'd given every product that we had, and we'd managed to get repeat results back. And if you compare these graphs to the last one, you'll see there is some improvement, but still not normal. The platelet function really didn't change despite 2 bags of platelets. So functioning platelet count is still only 38,000. The clotting time, CFT, and A10 have gotten better, but they're still abnormal. So this patient was still bleeding massively and had abnormal coagulation. So we gave a second set of blood products. So the patient got 2 more units of red cells and a few more units of cell saver blood, 2 more bags of platelets, another 4 units of plasma, and another 4 grams of fibrinogen concentrate. So that took about 45 minutes to do all of those things. Now we have our second set of tests third set of tests at 4 o'clock. And these are relatively normal. In fact, if you look at the numbers, they're all within normal ranges now. Your clotting time is 77, CFT is 91, A10 52 at the XTEM, and A10 is 12 at FIPTEM in the bottom. And your functioning platelet count is now over 100,000, and your total platelet count is 143,000. So these are perfectly normal coags matched with laboratory coagulation assays that were also normal. But unfortunately, this patient was still bleeding. So this is what we call a refractory bleeding. And the bleeding was such that the chest couldn't be closed. So it needed treatment. And here's when we get into rescue therapy. And there's really two options right now available for rescue therapy, which is recombinant factor 7A and prothrombin complex concentrate. Which one to use right now? Our practice, we usually use PCCs before factor 7A, but not that long ago, we would have gone straight to factor 7A. So we gave that to this patient and the bleeding stopped. So to put it all together, we had massive hemorrhage with liters and liters of blood loss in this patient, but within an hour and a half to 2 hours, we were able to control it, not using that many allogeneic blood products. And definitely, if you look at the numbers that we use, it's not really any ratio-based or empirical therapy. It was treatment guided by coagulation assays. So we gave 6 units of red cells and a lot of cell-saver blood, 8 units of plasma, 4 doses of platelets, 8 grams of fibrinogen concentrate, and then in this case, we use factor 7A as rescue therapy. But now, if this case was happening, I would probably use PCC before factor 7A. So to sum it all up, I presented some information in terms of how cardiac surgery differs from the usual management of massive hemorrhage, and in terms of prevalence, prediction, preparation, and physiology. I showed that massive bleeding is common in cardiac surgery and happens in about 20% of our cases. In most cases, we can prepare for it. There are cases where it's unpredictable and we might have to revert to MHP and 1:1 or 1:2 transfusion ratios. But for the most part, we can prepare and do coagulation assays and therefore be able to avoid calling an MHP and doing a targeted therapy of the bleeding. And then the physiology I mentioned, our targets are to treat the platelets, low fibrinogen, and thrombin generation. And with that, I think that's the end of my presentation. Thank you very much.